You are muted, Alok.
Okay. He is internationally recognized for the interdisciplinary scholarship bridging modern science and ancient Indian knowledge tradition. His writings and research emphasize the contemporary relevance of Indian civilizational values with core research interests spanning Ayurvedic science and technology, yoga, consciousness studies, Vedic education pedagogy, and the Vedic social and political tradition. In addition to his academic leadership, he is the president of Prime Bio, a biotechnology company with over 19 years of experience working in advanced areas including botulinum toxin, vaccine, antibody detection, and diagnostic drug delivery system. He maintains a strong academic association in India and has collaborated with leading institutions such like Jawaharlal Nehru University, New Delhi, University of Delhi, Puducherry University, among others. He is distinguished honors of award including Chancellor Innovative Teaching Award 1995, Scholar of the Year Award 1995 at UMass Dartmouth, the Henry Dreyfus Teachers Scholar Award 1997, the University Service Award 2004 from the UMass Dartmouth Alumni Association, recognition from the New Bedford Area Chamber of Commerce 2008, and selection of Chancellor's Colloquium Speaker 2009 at UMass Dartmouth. In India, he has delivered many lectures such as the Dr. B.K. Singh Memorial Lecture at the University of Allahabad and A.C. Mukherjee Distinguished Annual Lecture at Department of Philosophy, University of Allahabad. So, with a very short and brief introduction, I would like to, invite Professor Singh to chair the session.
Thanks. Thank you so much, Alok. If it was a brief, then I don't know what would be if it is very expanded. Well, it is my great honor to actually introduce today the speaker who has been in some sense an inspiration. I visited him in 2008, I think, and he took me to some medical school. I don't remember which one it was. And there we discussed how can we find a way to provide cheaper medicine in India. And in some sense that was stuck to my head. And when I was looking into that possibility, and it has worked out. It could work out better. I think that we might play a role not just in India but in the rest of the world as well. At least that's the ambition. But so the speaker, Dr. Nirmal Surya, is a senior neurologist and a leading figure in neuro rehabilitation based in Mumbai. With over 30 years clinical experience, he holds an MD degree in general medicine, and he is a diplomat in National Board in neurobiology, which is the first thing I learned, that they need diplomats in neurobiology. I thought they normally just need neurology. And is a fellow of Indian Academy of Neurology and American Academy of Neurology, as well as member of National Academy of Medical Sciences. He is the chairman of Surya Neuro Center. I applied for it, but he didn't allow. And founder trustee of the Epilepsy Foundation of India. A former president of Indian Academy of Neurology, Dr. Surya has held key leadership roles in national and global neuro rehabilitation bodies, including, I don't know the acronyms of it. So you can just imagine that he's really great supporter and advocate for neurocare. And he has been, even this morning, has been telling me that we need to find a way of explaining general people about neuropsychology. And so you all have an opportunity to interact with him. I'd like to invite Dr. Nirmal Surya for his
Offset, I am here only because of Balram, let me tell.
honestly confess that. And thank you so very much. I really, when he asked me that you come to Lucknow, and I said, what am I going to do with the scientist? I'm a clinician and I deal with the patient every day in and out. So to sit with the people who are working in lab is more challenging, because for me that is very boring part. I am very excited talking to the patient, listening to them. But then he said he wanted me to talk on cognition and looking at how the Alzheimer's disease has been spreading not only in the West but also a challenge in India. And I saw a patient just on first day come from one of the state of India, from Madhya Pradesh, and she come after 5 years of having symptoms, and now with the severe dementia that she tell her husband, he is my bhai, he is my brother, and no, he is my father, and telling the son that he is my brother. So, you know, coming at this stage and not even realizing that family people not even realizing that, you know, the dementia has gone into such a state. So that is what is worrying me. And while on one side, I'm going to talk about how on one side we can do the primary prevention, and on another side, early treatment, and then if we don't have anything, then we need to look into the rehabilitation. So if I can move my slide. Right. So when we talk about, we want to know, when does cognitive decline really begin? So you can have, you know, early late clinical symptoms. So I talked to you about this lady who is just 52-year-old, just saw a couple of days before, and memory loss and cognition symptom appear late in the disease trajectory, often years after the biological changes. And that's where you guys can pick up the things much early. So, you know, pathology of neurodegenerative changes begins silently decades before the clinical manifestation, accumulating gradually over time. It is like, you know, when a building collapses, the cracks start coming much before. So that is exactly we need to understand. So you need to establish the biology. By the time memory fails noticeably, underlying disease biology is already firmly established in brain disease. And that's where when clinicians start looking, we have no treatment. And therefore, critical window for early intervention are frequently overlooked due to the absence of visible symptom. So how do we do that? So why delaying cognition decline matter? So, you know, if you look at individual impact, cognitive decline is leading cause of loss of independence in older adult, affecting quality of life and autonomy in fundamental ways. So Alzheimer's is, you know, is a one disease which substantially contribute to the year-lived disability worldwide. And even modest delay in symptom onset translate into the meaningful function preservation for a very long time. So, you know, suppose a person can eat himself. So the husband tell me I have to feed her, I have to do everyday activity with her. That means bathing, dressing, toileting, everything husband has to do it. And she's just 55 years. So how many years he's going to do? And Alzheimer's is not a disease where patient is going to die soon. So you can understand that how much burden on the family is there. And therefore we need to really look into this, that how do we you know, do that. So now if you look at biology before symptom, and this is where you guys can, you know, change the things, is there's an amyloid accumulation, then there is a tau pathology, then you have a neurodegeneration which begins, and then the clinical dementia appear. So by the time we are looking at clinical dementia, you have already passed through the phases 3. And these are the beta amyloid plaque which accumulate silently in the brain decades before any clinical symptom. And tau pathology, tau protein, which is a protein, tangents correlate closely with neurodegenerative pattern and disease progression. So if you guys work on something where you can, not allow tau protein to deposit into the brain, not allow the amyloid to deposit in the brain. So what are those receptors you could change? Because then you can change the meaning of life for millions. Now, cognitive decline is a continuous. It's not a cliff. So if you look at understanding dementia as a gradual process, fundamentally changes our approach to intervention and care. So there is a gradual unfolding, which is a neurodegeneration gradually across the lifespan. Then there is a cumulative injury. So everything keeps on adding. And then there are multiple points like numerous intervention opportunities exist throughout the disease course, from risk factor to rehabilitation. So you could try and intervene at any of these stages. And finally, beyond single fixes, so you have single late stage intervention alone are insufficient. That means meaningfully after the disease trajectory. So you do anything at that point of time is of no use. So what does prevention means in neurodegeneration? And neurodegeneration is something where you scientists can make a difference, and not only in bringing the new medicine, but also in understanding how best one can prevent that. So you can delay the onset, postpone the appearance of clinical symptoms through risk modification and brain health. So, this is what we are advising. Do regular exercise, eat well, sleep well. So these are the things which can delay the dementia. Then slowing the progression through the some process by targeted intervention. And then, redefining the prevention. And finally, preserving the function. So we need to look at all the three factors. Now, comprehensive cognitive delay prevention framework is primary prevention, secondary prevention, and the tertiary management. So these are the few things which you need to look at. The biomarker screening is primary prevention, and now we got some biomarker. We can do the tau protein, we can check the amyloid through the CSF study, and those are available in the blood also. Then secondary prevention is there are anti-amyloid disease modified therapy. So these are lecanemab and donanemab. These are the two drugs which is FDA approved, now available for past 2 years. Very expensive, but they are available, and in India also we are going to have them in April. And then tertiary management, which is the symptomatic care, cognitive rehab, lifestyle intervention. So I'm going to give you a brief about primary prevention, secondary, as well as the tertiary, that's rehab. So there are clinical data, and there is an integrated MDT approach which is available. So you need to have a stage-specific framework to delay the cognitive decline. So effective dementia prevention required tailored approach, matched to disease stage, each with distinct goals and evidence-based intervention. This is what we are looking at. So there is a primary prevention, you have target is preclinical disease and at-risk population. Secondary prevention target is early symptomatic disease and mild cognitive impairment where the drug works. So your goal is slow progression and delay functional decline. And finally the tertiary progression where the prevention, where established dementia with functional impairment. Look at what are the functional impairment. Goal is maintain independence and dignity as long as possible. So now suppose this lady has come to me earlier and I have given her treatment, and she was not dependent on for her activity of daily living for next 2 years. I would have done great for her because the family would have still continued to do the work rather than hanging on with the lady. So that is something which we have to look into. So Alzheimer's disease is driven by ongoing and interconnected toxic pathways. And you can see the changes in Alzheimer's disease biomarkers which precede the onset of clinical symptoms. You can see them very well, and you all know more than me that how this works, because this is something you guys has been working, and biomarker abnormality can manifest even years, even decade before the clinical symptom occurs. And I'm not surprised when people are talking about the genetic analysis and doing it at the birth and identifying that this gentleman is going to have the risk of following diseases in the future and then can start working on that to the prevent. So that is something which is going to happen in next decade, because now that we have matched the human genome, now we start knowing that what are the changes happening, and I think next decade we will be able to find out what a person when born, what are the diseases he is prone to, and then he can work on preventing those diseases for the future. Look at AD pathophysiology, and you look at the ADN framework and cognitive decline, and if you look at all that, amyloid tau neurodegeneration cascade. So these are the two villains for the Alzheimer's disease. Amyloid is accumulated in preclinical stage and 15 to 20 years before. So if you could have a screening at 40 years, 50 years, and you start knowing that, okay, this girl has got, now you got fMRI, which can be amyloid MRI, and you can exactly match the deposit. So those patients who are at the risk can have every 5 or 10 years this fMRI to check the amyloid deposit and can get the medicine which can remove the amyloid from the brain. And then you have a phosphorylated tau which can correlate with cognitive decline trajectory, and these two lead to neurodegeneration, progressive synaptic loss, brain atrophy, NFL. These are biomarkers which are raised, so that gives you an ongoing damage. And cognitive reserve concept we have, that we, post-head injury or post-stroke, every patient improves, younger patient improve more. Why do they improve? Because there is a cognitive reserve in the brain. There's a brain, as we all know, that we are only using nearly 1/3 or less than even 1/3 of our brain function. 2/3 is just sitting there. So that is your cognitive reserve, and how much reserve you have kept alive. These are like FDs. And if you keep on getting interest on those FDs, that means you keep on using that reserve, keeping that active. You are doing your KYC regularly. That means that is available to you. If there is a damage occur, you can reverse it or you can improve it. That is the basic concept of neuroplasticity. And that is why 20 years ago when people were thinking stroke means finished, no treatment, go to sleep, has changed. And now we have brainstem stroke patient completely recovering. So these are some of the things we have understood over a period of years. There are individuals with amyloid pathology on the AI continuum, and these are the other biomarkers which are there. I think I don't understand much, but you guys will know that how many ATN profiles are there. And AD begins with deposition of amyloid plaque, which then lead to the tau neurofibrillary NFT triangles and neurodegeneration. So this is these three people, when they meet, the two people then will meet together, then they create the degeneration. The biomarkers are reshaping the patient journey. That is why I have come here to talk to you guys, that we clinicians are looking at you, because we are seeing end stage, final stage when patient is already come. But you can change much before, when the person is not even symptomatic, when not even have any problem, and he says, oh, I'm fine. But you can say, no, after 10 years, you're not going to be fine, be alarmed. So that is where it is important. So you have initial evaluation, then you have laboratory tests, then you have cognitive, behavior and functional assessment, and then you have neuroimaging. So this is what we do now. We evaluate the patient, and then we do the laboratory test, and then we check the cognitive functional through our neuropsychologists assessment, memory assessment. Then we do the MRIs and functional MRIs, PET scan, and then we start looking at biomarkers. And this is where we are growing. We don't have biomarker yet available freely in India. There are only few centers, and these biomarkers are very, very expensive, mind you. I've sent one patient's report to Niemans. They are doing a research on Alzheimer's disease for this biomarker. 2 months, I have not yet got the report, because they must be doing once in 3 months or once in 2 months. And I want to do the amyloid PET scan, but this is available in Singapore. So if I send that patient to Singapore and get this done query, and then we monitor the treatment response to the disease. And this is what exactly the roadmap for the people with Alzheimer's disease. So mixed pathology. Why amyloid alone is not the full story. So we know these two, but there may be more villains sitting inside which we don't know. That you have to find out. You will look into it that okay, amyloid is there, tau is there. These are two visible, but who is behind them? It's like two goons killing, but there's somebody else sitting in the politics up who is funding them. So you guys have to look at that biomarker, that this is what when is there, redirect these two to come together and make the brain degenerate. So we have the majority of dementia cases do not present as pure Alzheimer's. So when we examine them, it means mixed dementia or focal dementia or vascular and Alzheimer's, because many of these patients are elderly, they also have diabetes, they also have obesity, they also have hypertension. So these things also add to the brain degeneration. That's why there is a mixed pathology. So you can have dual pathology dominance, like cerebral small vessel disease, white matter changes which can happen over a period of year, maybe because of vitamin deficiency, maybe because of other associated illness, and the vascular risk control which I told you about, hypertension, atherosclerosis, diabetes, etc. And then of course is genetic. So cognitive reserve is what we are talking about, is a hidden modifier of decline. So cognitive reserve represents the brain's adaptive capacity to maintain function despite accumulating neuropathology, and this mechanism explains why identical pathological burden produces vastly different clinical presentation across the individual. So reserve framework is there. Then you have a clinical implication of this reserve, because there is a butterfly functional impact without halting pathology, modulate individual response to therapeutic, inform prognosis and care planning, and justifying cognitive engagement intervention. So primary prevention is cognitive normal with biomarker evidence. So you have blood biomarker screening, ApoE4 genotyping, and AHEAD trial, which is NIH phase 3 trial, where lecanemab in preclinical Alzheimer's disease results are there. We are going to talk. And there is a cognitive reserve enhancement and timeline to minimum cognitive impairment. So MCI is something which is important. 10 to 15 years from biomarker positivity to cognitive symptom is what you are looking at. And if you can pick up a patient at MCI, because MCI means there's a minimum cognitive impairment, and this patient, if the family and patient recognize that not everyone who says I'm forgetting is MCI. So if we can recognize this MCI, there is a treatment which can be offered to them. There are modifiable lifestyle risk factors. So you do exercise at least 150 minutes per week, aerobic you can do. And it increases the BDNF, cerebral perfusion, hippocampal volume preservation, because that is where the memory is all about. Cognitive stimulation like learning, puzzling, reading, music, social engagement. Many of us are living in an isolated place, alone. That's where is another problem. So it causes synaptic plasticity and cognitive reserve accumulation. And then cardiovascular health, that means blood pressure control, lipid control, diabetes prevention, and effective reduced cerebral amyloid burden through the vascular protection. So these are the must for everybody. It's for common people, for every individual who is above 40 and even younger, because they are growing and we don't know what is going to be impact of this environment where we are living in next 10 years time. The most important is sleep. And I was talking to Wim and he said, I was not sleeping some days ago. And sleep is a biological modifier of neurodegeneration. And there can be slow wave sleep, there can be a glymphatic clearance and reduced neurodegeneration so degeneration. So sleep represents a modifiable biological pathway with direct impact on neurodegeneration through the lymphatic clearance system. So we were all these years were hearing the lymphatic clear. Now in the brain you are having a lymphatic clearance. So this is something again come from scientists and biological workers. So clinical action point is screen for an aggressive treat sleep disorder as a part of disease modified strategy. So the sleep apnea is something which is very, very common, hidden sort of a epidemic. And those who do not sleep and snore during the daytime, not necessarily that every obese only will have sleep apnea. There are many patients who are not obese also have sleep apnea, and doing a sleep study. Nowadays you got a good watch, Apple Watch can match your sleep study, and it can give you the how your sleep cycle is. If you wear it and sleep for 3 days, it can regulate. So these the wearable digital gadgets can help you in picking up the sleep disorder. I recommend this for every individual to at least check once and see that you don't have any sleep disturbance, particularly those who are not sleeping well in the night and excessive sleeping during the daytime, or sitting and just doze off. So who is disease modified therapy for, and where we are looking at? We are looking at DMT for Alzheimer's disease, are specifically for patient in the early stage of the disease continuum. So that means at MCI. And the evidence base for these agents come from large phase 3 trials of anti-amyloid monoclonal antibodies, and 2 of them which we are going to talk, which define clear boundary for appropriate use. So you can use at mild cognitive impairment, mild Alzheimer's dementia, or not for, but these are not for advanced disease. So they are not indicated for moderate or severe dementia stage, because they are not going to clear those amyloid because they are not capable. So the foundational evidence derives from pivotal anti-amyloid trials published in NEJM 2023, guided by the research framework for Alzheimer's disease. So these are what I'm going to give you in some brief in next few slides. Anti-amyloid DMT stage is MCI, mild dementia, and this is the treatment window. There are inclusion criteria: 50 to 85 year age, amyloid positive biomarker or PET, MCI or mild dementia phenotype, which comes through the clinical neuropsychologist evaluation. And then you have lecanemab, which is Lecumab, very expensive, FDA approved in 23-24, now available. And then you have cognitive decline prevention goal, extend independent 4 to 6 months. So even independence for 6 months is a positive trial. And then another one which is coming is donanemab, which is Kisunla. This is anti-N3-PG modified, and it is a monthly IV. So you can use it. This is bi-weekly IV, and that is monthly. So from clinical syndrome to disease-modified therapy, this is what we are looking. We have to do the clinical recognition early, safety screening, biological confirmation, and shared decision making. So this framework aligns with the biological research framework, and that's where exactly is clinical pathway. And this is lecanemab beyond amyloid plaque clearance, and you have soluble, insoluble, which is they target the protofibril and plaque clearances with downstream impact on tau and inflammation. There are eligibility and exclusion criteria for disease-modified drug, and we have to carefully select to optimize the treatment benefit for these drugs from phase trial. And these are the eligibility, there are the exclusive criteria, and ApoE4 consideration, which is associated with substantially high rate of area E and area H in the lecanemab trial, occurred in appropriately 15% of patients and 8% in heterozygote and non-carrier. While not an absolute exclusion, ApoE4 status should inform risk, counseling, and may influence the monitoring. So these are some of the things which we have to look into when we start the trials and we are giving this. But these are the phases which has been studied, and 2 double-blind placebo-controlled trial has come, and these shows that this has increased the daily living and mental function stable for 6 months in most patients, more than 50%. This is not available in Canada yet, but US it is available. This is another study which control and parallel group randomized with different clinical criteria and exclusion criteria. Doses was 10 milligram per kilogram every 2 weeks, with assessment in the 18 months placebo control portion of phase 2B. And This trial also showed a effective treatment. So there is a meaningful benefit across primary and key secondary endpoint at 18 months. So this is what is new today in Alzheimer's treatment. Give some ray of hope and also a scope for you guys to look into something more which can give you more. So this is the beginning. Now how can you enhance further on this? This is study 301, which is overall safety profile of this drug versus placebo. There were two deaths which was reported. So there were 0.8% in placebo over 0.7% in the lecanemab group. So overall it is quite safe. Secondary prevention in phase 3 RCT, nearly 2,000 patients with early Alzheimer's disease. There were primary endpoint and clinical interpretation was that patient maintained ADL independence, delayed transition to moderate dementia is told, and there were 93% achieved amyloid clearance through the PET scan. So you do the PET scan before you give the treatment and you repeat the PET scan and you can see that there is a 93% clearance with this 18-month treatment. So what does slowing cognitive decline mean clinically? Yeah. These are interpretation in the clinical trial. So there is a primary endpoint result, 27% slowing of decline on CDR-SB scale. Then there is a real world interpretation, that means a delay in the loss of independence by an established 4 to 6 months over 18 months. And then patient-centered outcome for patient and families. This may translate to several additional months of maintaining activity like managing finance, active safety, or participating meaningfully in the field. So even this 8 months, 6 months is something which is important. So these findings are derived from landmark. This is there in the NEJM 2023 publication. Donanemab trailblazer efficacy 76 weeks. So this is phase 3 trial. Primary endpoint was 35% slowing of cognition and functional decline versus placebo. CDR-SB benefit was 25 reduction in cognitive decline progress. Subgroup advantage, greater benefit in low and medium p-tau participant. Dosing convenience because monthly IV once a month. And these are comparable class effect with monitoring protocol. So once in a month is better than twice a week. And again, secondary prevention, the amyloid related image abnormality surveillance has been done and it shows a better clearance. And clinical feature and management in amyloid related imaging abnormalities represent the principal safety concern with anti-amyloid antibodies. Area encompasses both edema, infusion, and microhemorrhage, hemosiderin deposit, as well as understanding recognition and management protocol is essential for safety DMT administration. So you have clinical presentation. Most area courses are radiographic. Then you detect and monitor them through MRI surveillance. Then you have an acute management upon, giving the medicine, and then treatment resumption depending on the patient response. So these are lecanemab versus donanemab. I'm not going to give you in detail, but both drugs target amyloid pathology and shows efficacy in phase 3 trials. So that's something. Both are effective. Now it is up to you, which is available to you, and the cost of medicine, and which patient can be afford. And this is for secondary prevention for the disease modified therapy, patient selection, and cognitive assessment. We go by evidence-based inclusion-exclusion criteria, age, biomarker confirmation, baseline neuroimaging, contraindication are APO, E4, relative case-by-case baseline microhemorrhages, and unstable cardiac or renal disease. So there you have to be maybe contraindicated. And you have to monitor the commitment like patient and care. You must agree to MRI surveillance. So they have to go again and again for the MRI. Infusion scheduled monthly, and the cognitive testing every 3 months, which is part of it. So these are the baseline testing and monitoring for DMT. Baseline evaluation, early monitoring, informed consent required, neuroimaging, ongoing assessment, clinical follow-up, and scheduling. Secondary prevention for the cognitive decline metrics and outcome measure Again, you have clinical dementia rating sum of boxes, ADA COG4 test, 70 point, which is ADRS, integrated AD rating scale. So these are Alzheimer's disease rating scales which we neuropsychologist has to do. As a neurologist, we just do MMSE and MOCA. These are the two which we have bedside cognitive screening. So when patient come to me, I do MMSE and MOCA. And then if I find them abnormal, I send them for the neuropsychologist to do the ADS, COG14 and ADRS, etc. Then you go for biomarker responses. We look at tertiary management, which is symptomatic, pharmacotherapy, moderate to advanced AD, early stage DMT adjunction. So you can add, along with that, there are drugs which have been available for us for years, like donepezil, memantidine, or combined between donepezil and memantidine. These all we have been prescribing for last 30, 20 years. And psychological management through SSRI, depression, and synergy concept between multiple drugs. So this is what normal Alzheimer's disease management, when patient comes to us, is what we are able to offer and we give it. Then tertiary management of cognitive rehab and neuroplasticity. So now we come to the evidence-based cognitive training modules. So cognitive stimulation therapy is something which we do. Cognitive training, computerized versus supervised, cognitive rehabilitation, personalized therapy versus various other gadgets, memory techniques. So we have space repetition, association method, simple thing like write down a note and stick it that you have to do the brush and keep the brush here, or after the wash you have to wash your hand. So you write down those things so that patient see them and follow them. And neuroplasticity principle, which we are going to talk. So multimodal exercises versus cognitive training efficacy is compared. So multimodal exercises, which I talked about, combined intervention, exercise plus cognitive training, aerobic exercises alone, optimum doses is 150 minutes per week, and cognitive training alone. So these are various things, but if you do multiple together, they have a better effect. Again, lifestyle and psychosocial intervention through the diet, caregiver support program. So when the caregiver support program, social engagement, occupation therapy, it give much better and slow down the therapy. Sleep optimization and reality orientation and remissions therapy. So you have DMT monotherapy, cognitive delay by 4 to 6 months. You have cognitive rehab alone, cognitive delay maybe 6 months, synaptic plasticity. And when you combine both, the cognitive delay can be 10, 12 months. So this is what is the now that you not only treatment but cognitive therapy is important. So you have DMT plus symptomatic therapy plus cognitive rehab plus exercise plus lifestyle is the maximum cognitive prevention is what you are looking at. So what are the clinical implementation and barriers and solutions? There are diagnostic challenges because we need to identify early. This is where we are missing. In India, after the stroke, when you have a thrombolysis, which can be done in 4 hours, only 1% people in this country reaches in the window period. So that is something we need to work. We got everything, but patient don't come in time. So early detection, that means the biomarkers has to be available at a low cost. DMT access, not yet available in India. Cognitive rehab availability. Unfortunately, there are not many trained neuropsychologists available in this country. As a president of IFNR, I've started with few, 5 to 10. Now at least there are 100 plus neuropsychologists in this country, and we're training more and more them, trying to see that how we can have more number of trained neuropsychologists to treat this patient, which is growing. And then patient expectations. We need to really talk to them, give the counseling, give them reality that how the brain functions and how it cannot be reversed. Then the patient husband asked me, can you not operate? His question. I said, I can't do much beyond this now, you come too late. He said, you cannot operate. I say, yes, only one person who can operate is go to Lord Shiva, because he has done the brain transplant, I can't do it. Ask him how he can do it. The only one person in this world. So that's something, reality we have to explain to the patient and their relative. And then we have to look at India-specific solution. We can't look at the West. We have to look at our own patient, how they are, where they are living. A little person living here in the farmer, and we tell him to come for robotic or VR therapy is not possible. Then you have neuroinflammation, which is engine of ongoing cognitive decline. So while amyloid deposition may initiate pathology, sustained microglial activation drive the ongoing neurodegeneration that correlate most strongly with clinical progression. And this is where you guys have to work on. Now we know that this is what is happening. Now we know that this is the treatment, but we don't know why the continuous inflammation is, and you need to look into that. So you need to look at microglial activation, synaptic dysfunction, systemic link, and then look at therapeutic target, which is which represent a critical focus for next generation disease-modifying drugs. So you have to look at that. And the therapeutic targets are clear. The inflammatory cascade, rather than protein deposit per se, may represent the most actionable therapeutic window for slowing functional decline in the future. So this is what I want to give it to you, that you guys need to work on that. What we know yet is enough, not enough, but this is where we are stuck up, so you take the lead from here. So what are the future direction? Anti-tau therapies and combinatorial approaches. So next generation cognitive delay strategy in next few years is anti-tau, monoclonal antibodies, dual anti-amyloid plus anti-tau, oral tau inhibitor, because we have to come with a drug which anybody can be given. DIAN-2 platform trial which is going on, and there is a potential, again, combined efficacy between anti-tau clear and anti-amyloid and rehabilitation. So the big work. So future direction in disease-modified drug, while anti-amyloid monoclonal antibody represent a significant milestone, they are best understood as a first step rather than a comprehensive solution. And the field is rapidly evolving toward more diverse mechanism, approaches, early intervention strategy, and combined therapies that may be more robust disease modification, anti-tau, neuroinflammation module, combined strategy, and preclinical evaluation. So amyloid removal represents an important proof of concept, but achieving meaningful disease modification will require multiple mechanism approach that addresses the full spectrum of Alzheimer's pathophysiology. And that is what I'm trying to tell you, that don't be a microscopic vision that we are looking at this and we'll clear this. You have to have a mega approach that this may not be enough. We need to look into the multiple factors which are causing this disease and we can tackle them. So you have effective intervention which will require targeting at multiple levels of the pathological cascade simultaneously. Monotherapy approach, this has to be treated like a terrorist. That means Punjab, Rajasthan, Gujarat, Kutch, everywhere you have to have the shield to protect. So this is how you have to work. Pathology initiation, progression drive, reserve modulation, and functional rehabilitation, and then use them in combined strategy. So key takeaway, evidence-based cognitive delay prevention 2026 is paradigm shift, proactive biomarker-driven prevention in preclinical MCI stage, disease-modifying approach established, DMT efficiency established, lecanemab and donanemab both, cognitive rehab equivalent, 6-month delay, combined approach superior to the alone, primary prevention emerging like in a head trial, and practical implementation, that is biomarker screening, multidisciplinary AD clinic, and realistic expectation setting essential for success. Do I have time to go into the rehabilitation part, or I stop here?
We will have to take some questions.
Yeah, that's why I said if you don't have time, I can stop here and I can talk on rehabilitation some other day.
A lot of mileage covered. Dr. Surya, you can see he has been practicing and caring. You know, this very interesting survey. They have surveyed people who are the most important professions. You know who is number one? nurses. Who is number 2? Grade school teachers. And number 3, doctors. And when I was in hospital in Mass General, I told this history to my doctor. And he said, you should always listen to the nurses. Because they are so caring. What Dr. Nirmal Surya is talking about, all the details about tau or beta amyloid and all kind of treatments is out of care. He's really concerned about it. He's a clinician, but he's concerned about the care of the patients. You know what doctor means? Test for him. You know what doctor means?
Nobody can argue with you. You have said
No. I don't mean to argue with you.
If I say something, you will give me some Sanskrit lesson.
No, the doctor is not a Sanskrit word. It means teacher. When you care, then only you can teach. That's what I'm trying to say. Doctor basically means teacher. So somebody who is as caring as he can make difference, especially about neuro things. When you talk to patients and if they really trust you, like he's saying that some patient came with who recognizes her husband as her brother or somebody. Actually may not be a bad idea. Sometimes, in talking about language, bhai is the pati is the English, it's a word for husband. Bhai is for brother. Bhai, यहाँ हम लोग लखनऊ में बैठे हैं. लखनऊ में जो भा जाए वो भाई है.
यहाँ पे तो जो वो भाई है.
Anyway, it's really wonderful to listen to. Fortunately, this center is doing something about monoclonal antibodies, and there is a good part. They have bi-specific antibody. They're not working on neuro-related, but they may get some inspiration from your talk.
We are working, sir.
There you go. I didn't even know. So there are secrets. People are working here. Maybe you will someday will be very happy about that. But also the botulinum neurotoxin that we use, there are so many factors, and some of them do change the tau and microglial cells and things like that. But we are also trying to manipulate that. Hopefully, with inspiration from your lecture, this work will move forward. But anyway, with that comment, I want to see if there are other questions. Yes, Manish.
So, thank you very much for your such an informative talk. Sir, we are also working on different projects related to neurology. Like we are working on axonal regeneration project, and as you have said, we are also working on few strategies to target the factors which lead to the tau or beta amyloid pathology. So we are working on that. So I would like to ask a question first of all, that is there any relation between the amyloid pathology and gut and kidney related problems?
Recently, the brain and gut has really been studied. Last 5 years, I am seeing that a lot of questions are coming between brain and gut. A lot of people are talking about infection in the stomach affecting the brain. We know that drugs like, we know that vitamins like B12, folic acid are clearly related to absorption from the gut and affecting the brain and the peripheral nerves. So definitely what we are eating and how it is modifying our brain and how these pesticides are changing our genetic and deposition into the brain is something which you need to study, because this has been happening in the last couple of years, decades. 50 years before we did not have much of pesticide, but now we are seeing more and more increase in the Parkinson disease, other movement disorder which were not there. So when we are talking about these various deposits in brain where we know about this, one is deposit, two is deficiency and degeneration. So if we look at all these, we will probably know more about not only Alzheimer's disease but many more other neurodegenerative disorder like Parkinson's and Parkinson related. We didn't know much about Parkinson's disease 20 years ago, but today we are seeing so many variations in Parkinson's disease as well as Parkinson plus syndrome. So certainly gut is an important point because that's where the person, what he deposited in his body and how the degeneration starts. I think need to be studied. Maybe the gastroenterologist and neurologist should sit together to do the research together.
And so another question, does this Alzheimer pathology or Alzheimer disease transfer from one generation? It has a hereditary link on...
There are clear genetic links now, and there are certain gene linkage which are there, then you are at a higher risk of getting the Alzheimer's. Same with the Parkinson's. Before we didn't know that Parkinson's can also be genetic. So now we are able to, because now we have done the genome for the human being. So we would keep on learning more and more about this genetic disorder because we are getting more and more cases. Same Alzheimer's also can be, and that's where it can come at 40 years and 45 years.
One last question. One last question, sir. As you said that this Alzheimer's disease or Parkinson's needs early diagnosis. So by looking to the patients who are having neurological problems or spine problem or some nerve-related issues. So by looking at that, can we recognize that that patient may lead to the Alzheimer's pathology?
As I told you that it is even 2 or 3 decades before the clinical symptom that starts.
Okay,
So you cannot find out. It's same like your kidney reserve. You got to have 2 kidneys, but you only need one half of the one kidney for your normal function. So unless that complete damage happen in one and another also get compromised, your creatinine don't go up. So same way you cannot recognize because clinical feature only comes when there is a significant derangement in the brain function. It's like you hear every day that suddenly person who's running on the treadmill fit, he died every day. Many of them, if you do, you find that the vessels are already blocked. But how do you do it? Either you evaluate them periodically to pick up. Same way, now we are getting biomarker and MRIs. So we need to do this biomarker and MRI in those with the family history or those who are in an environment which is conducive to the Alzheimer's or degeneration. There you do it this every 5 years or every decade to find out that who are at the risk, and they should be continuously followed up.
Thank you, sir. Thank you. Any other question?
Would like to know the general things which we eat during the day, especially in India, haldi and adrak and this lasan, etc. How does it help?
I do not have any data to tell you that what is good and what is bad, but haldi is supposed to be one which has got a lot of effect on the brain and the body in general. But what we are telling people is eat healthy food, that is the brain health what we are talking about. That includes the good amount of vegetable, fruit, protein, and the balanced diet, everything excess or less is a problem. So you have a balanced nutritional diet which you should follow as a part of the brain health.
What about those other additives as being explained about the algae, which they back up as spirulina and things like that,
Spirulina was, there was one drug extracted out of spirulina which has got dopamine activity. So that was used for the Parkinson's disease. So we have done that. I really do not have much experience on the Ayurvedic medicines, and many of them are helpful, but how much and what doses and when to be consumed, who should consume, I really don't know.
Should the organization work on these areas to find out certain things as to mark those patients and
There is see the day by day when we are looking at the drugs which we use them, they have a lot of side effects. So there's no allopathic drug which do not have side effect. Even vitamins has got the side effect because they can give you allergy and they can cause toxicity. I strongly believe that Indian system of Ayurveda has been known for years and years. There are a lot of examples where people would diagnose all with only the pulse with various kind of illnesses. There was treatment for the strokes, surgeries, etc. Brain surgery has been planned out. So what we need is a good research. They all were done on those eras. Now we got MRIs, we got functional MRIs, we got CT scan. We can study the potential of these drugs along with a proper research protocol, doses, amount, duration, everything can be. Because what is happening is people think that Ayurvedic drug is not a drug. Many of my patients who come with symptoms of peripheral neuropathy, early difficulty in memories and many other symptoms, when we talk about them, do you take any Ayurvedic medicine? They say no. And then I have to talk them, do you take any Chyawanprash like thing? Most of the people are taking tablet for the constipation. They are already khatam. So when we evaluate them, many of them has arsenics, lead. So they causes toxicity because they've been consuming them for years and years and years. So thinking that Ayurvedic drugs are safe, and they are not drugs, they are like chocolates. So I feel that we need to have established a proper scientific forum, doses, duration, with the guidelines that you can't just keep on consuming for years and years and years. There has to be some protocols, there has to be established. You just can't go on to a shop and buy the things and you start eating. These are something which I feel that has to be standardized, and unfortunately they are not. And even mindset of the patients in India is that they are not drug.
Basically, I was very keen to understand that what really helps to avoid those deposits. If some blood thinners or things like that, or maybe
No.
something Ayurvedic is developed on that.
One will have to do the research. I am again
Okay.
not a researcher, I am a clinician. I see only end result.
So you must attach some people who can go along with you. Thank you.
I had this question about how psychological disorders such as schizophrenia or major depressive disorders could either affect or speed up the deterioration of the neural pathways.
I think it's most complex subject, and I'm not an expert in this. You have to go to a psychiatrist who can explain you. I believe that when we talk about brain, we talk of dimag and brain. So these are the subconscious neurochemical disturbance, particularly happening into the frontotemporal areas, and that causes that neurobiology is most complicated, and I don't think I understand that at all. But there are many patients with brain disorder who present with neuropsychiatric symptoms. Even Alzheimer's comes with behavior abnormality, cerebral palsy, the epilepsy, many of them where the frontal and temporal lobes are involved, pathologically or neurobiologically. So it may be either a damage, electric damage, the neurochemical damage, or non-functional damage. The symptoms can be of the psychosis or like schizophrenia. But this is the most complex subject, and I think the most research with fMRI is on this, and that is something which is beyond me.
One more question.
The last one.
Thank you, sir. Thank you very much. I just have a single question. That we were earlier talking about the sleep disorder.
Yeah.
So it's just the sleeping pills. Many are taking sleeping pills, but I have by myself I have used melatonin for better sleep, and you have said that it is deeply related to our these neurological disorders. So do you have any data that in longer term melatonin
honestly, in my 40 years of practice, I have never used melatonin. It's the most hopeless drug which people are using. Millions rupees they are buying over the counter. I think I tell my patient, take this and throw into the Arab Sagar, which is just 100 meters away from me. The sleep hygiene is the most important. The most people have to understand that they need to sleep in time. There cannot be more than half an hour difference between everyday sleeping. They need to eat. In Indian philosophy, if you look at Jain, sleep, eat before sunset, wake up before sunrise. And that's where exactly your body responds. Your biological system and the neurochemical system is such that if you follow that, regular exercise. And the biggest culprit today is this. I tell all my patients, 10 o'clock, put the phone in your lock. Tell the parents, put it into the lock, so that your child sleep in time and wake up in the time. The sleep disorder are self-created, except for the sleep syndromes which are, OSA or obstructive sleep apnea or sleep apnea related to. They are not happen to everybody, but rest all people are because you do yoga or meditation, you eat in time, you do regular exercise, and you sleep in a cycle where your biological clock gets set up. I don't see that you won't get sleep. Medicine should be used in exceptional cases. All medicines are either dependent or causes daytime drowsiness or the rebound phenomena. So I only recommend SOS, and with those patients like Alzheimer's who can harm themselves not sleeping, their symptoms of psychosis can aggravate during the day. Except those circumstances, do not use any sleeping pill. That's my strong suggestion. And melatonin, throw that into the stream.
Arab Sagar.
And not Indian Ocean.
We, even though we did not want to make an exception, but Rajkumar is the boss of this conference. So if he raises hand, I guess we have to yield.
Thank you.
Yes, you are. I have to live, so I have to. Yeah.
So,
Use the microphone.
so you know all the physiology of that Alzheimer disease, where tau aggregation and the amyloid beta aggregation.
If we can see you on the screen also, please, on that side.
Come.
Come along.
So in normally whatever the drug you mentioned and the clinical trial drugs, they are all after the plaque form or after the aggregation, they are treating the aggregation and reducing the aggregation like that. Do you know any drug which can prevent the formation of these plaques or the aggregations?
I already mentioned that primary prevention.
That's
That's it, lifestyle management.
But I am asking because we are thinking of when it happens decades earlier. So if we can know the mechanism of that, then we can prevent that part early.
That is what is the whole thing is that we need to recognize MCI much before the clinical symptom. That means now we are doing is biomarker assessment in the patient where we find that they are high. That is where you can start these drugs. These drugs are only working when there is a minimum brain degeneration has happened. Only deposit is there, but brain degeneration cascade of inflammation not yet started. That is where these drugs are available. To reverse the neurodegeneration, we still don't have a drug. So maybe you have to work in future. Stem cell has failed because we thought stem cell something they will grow the brain, but they haven't. They still have to look for some DNA or something which can produce the brain, like in the worm the brain is being produced. Like that, if somebody can grow the brain. Another challenge for you guys. You have grown the baby into the test tube, but can you grow the brain in the test tube?
Thank you.
Okay, well, all the good things end, so it seems obviously, this is a very fertile topic. And we have been discussing since yesterday. He talked about Shiva. And we know why Shiva cut the head and put the head back? Because Ganesha was asking questions. And so you have to ask questions to get it fixed. Yeah, you have to ask questions that people like Dr. Surya. So thank you very much for this. And what is the next? Okay, thank you. Thank you so much.
You will felicitate. Oh, felicitation. Okay. Please.
Thank you very much.
Wonderful paper, sir.
I have prepared it in last 12 hours.
Yeah, my God. Such a hard work.
It's kind of difficult to put on a Thai person this song. He does public service also, so has organizations where people come and get benefits. I participated when I was in there. So he really means.
Run the foundation for patient with epilepsy. I run the epilepsy foundation. Every Tuesday I see about 100 patients.
What is the location, sir?
Mumbai. And in our NGO I have employed 14 to 15 patients with epilepsy. They run the center. They make a lot of things like paper bag, many artifacts, garland, Marathi, diyas. So, we have created employment for them. I have done the biggest project on epilepsy in Maharashtra with Government of India National Health Mission. Done 106 camp in 12 years and saw more than 40,000 patients in Maharashtra across all the districts. So that's created a model, Maharashtra model of total epilepsy care where a team of 40 to 50 people will travel with me, including 10 neurologists. Average 300 to 400 patients in each camp. Complete rehab team, so two psychologists, 2 physio, 2 OT, 2 speech therapists, 5 EEG machines to do the 50 EEG free that time. So we created and 3-month medication free to all the patients. So that is something which we have done and I have great satisfaction. I've also created one of the best neuro rehab training across the country. And not only country, I'm also the president of Asia Oceania and I'm the Secretary General of World Federation of Neuro Rehab. So we are doing a neuro rehab meeting and cognitive rehabilitation is one full day program on 9th April. So those who are really interested in cognitive rehab, there are 3 international speakers coming. And it's a very comprehensive project, including the dementia rehab. So those who are, I just give some class, those who are interested can come. It's a total meeting, which is rare because, and it's at very low cost I do it because I want for the training and teaching.
Possible online also?
No, this time I've just kept the physical because there are 70 international speakers are coming because Lancet Commission of Neuro Rehabilitation is coming, European Federation of Neuro Rehabilitation is coming. So I don't want online things to dilute their presence. Balram Singh is coming and modern boxing.
Now you can see the effect of Bollywood.
Thank you so much, Dr. Shauryaji. It was such a great talk. Now we will move to our next session, and the theme of session is cellular and molecular basis of cognition. In this session, we have 4 speakers. 3 of them are online. And this session will be chaired by Dr. Gajendra Pratap Singh. I would like to say a few words about him. Dr. Gajendra Pratap Singh is an assistant professor at the School of Computational and Integrative Sciences, Jawaharlal Nehru University, Delhi, and an associate National Cadet Corps officer with 2 Delhi RD, BTY and CC. He earned his PhD in 2013 with specialization in Petri nets and graph theory. His academic interests span advanced computational optimization, digraphs, system modeling, and interdisciplinary applications, including Indic knowledge system. He has designed and coordinated several optional and online courses at JNU and has served as visiting faculty across multiple schools, including mathematics, computer and system sciences, and Sanskrit and Indic studies. With a big round of applause, I would like to invite Dr. Gajendra Pratap Singh on the stage.
Very good morning to all, and thanks to Professor Balram sir and his team for giving the opportunity in this very mega program. So this is session 6, based on cellular and molecular based on cognitions. The first speaker of this session is connected by online mode, Dr. Chandrasekhar Mayor Anil. Dr. Chandrasekhar is a neuroscientist and former director of pediatric neurosurgery research program and Allen Clark research scholar at Robert Lurie Children's Hospital, Chicago. He has cited more than 50 research articles, publication in development, neurobiology and pediatric brain tumors. He brings deep scientific expertise to his works. A long-time practitioner of yoga and meditation, Dr. Mayanil is pioneer in the field of yogic neuroscience, interpreting yogic practices through the lenses of modern neuroscience to bridge ancient wisdom with contemporary science. With this, I request to Professor Chandrasekhar, you can start your talk here, and you have 30 minutes, sir. You are most welcome this conference. And after 30 minutes, we can have some questions from the audience. Thank you.
Thank you very much. Thank you so very, very much. I greatly appreciate Dr. Singh. And of course, the boss of the conference, Dr. Raj, who I have a great fascination and a lot of respect for. And above all, of course, Balram Singh, who has been my classmate, and he is a buddy. I would say he is just a cool guy, all right? So I'm going to share with you my PowerPoint. I guess that's... Hey. Are you able to see this clearly?
Yes.
Okay, great. So the topic of today's discussion is cellular cognition in neuroimmunology. This is the typical life science interdisciplinary topic that I'm taking up. And thanks to Balram Singh, we always have brainstorming sessions on such things. As somebody says, you cannot argue with Balram. So I don't argue with him, I just listen to him. And that's how I learn a whole lot, just by listening to him. Okay. Now, this is the overview of the talk. Cellular cognition is what we will be talking about. Then since it is a cellular cognition in neuroimmune system, we will be talking about neural cell cognition and immune cell cognition, and then the neuroimmune interface that happens. And then we will talk a few case studies, how this whole thing works together, and apparently therapeutic implications and future directions. So it all started, cellular cognition is a cool term of present generation. Earlier, we used to talk about signal transduction or receptor-mediated signaling and cell talking to each other. But now it has become a very highly interdisciplinary field because of so much of research going on. Now, cellular cognition term came, of course, through this entire system. But when you deal with one cell at a time in petri dish, for instance, then what happens is you do not apparently see the entirety of the picture, right? So what happens is you may get an output when you put a ligand and the receptor binds, it phosphorylates some protein and get to the nucleus and all that stuff happen, right? But if you take two different cell lines together, there is a totally different effect. Even though the other cell also has the same receptor, but now when you're putting together, both the cells behave very differently. Now that is basically getting into systems biology approach, right? When you combine one with another and then with another and another, the entire thing goes out of prediction. There is no prediction. And that's why I do not ever believe in this concept of a targeted medicine. The moment you put it inside the body, there is no target. It's all non-specificity happens so deeply. That's why the formulations in Ayurvedic medicine, I should never in neurobiology that it is about